about the idea of Pallor and how we might think of a structured approach to the pale child. Now, I want to be clear what I'm not talking about. I'm not talking about the skin tone of the child. And indeed, pallor is going to be difficult to assess in children with different skin tones. And it's important that we understand that what we're talking about really is how the capillary bed is perfused and how the capillary bed is made pink, either in the conjunctiva or on the palms of the hands or on the lips, and how that might look different if it's not normally perfused or if it's perfused with blood that doesn't have enough red cells in it. So really, when we go and see a child, we might observe that they look pale, or the parents or carers might have observed that the child looks pale. And we need to distinguish between skin tone and problems with skin tones, such as vitiligo or changes in the skin that might happen because of a fungal infection. And what we're really talking about today is changes in either the perfusion or the amount of red cell in the capillaries that we might examine. I would strongly recommend that when you're thinking about this, you take the time when you're assessing children to take a step back and look at them and think, do they look more pale than one might expect them to do? Particularly, we're going to look at the conjunctiva and at the lips and at the palms and the nail beds of the child. And you might notice that when you look at the hands and you might put your own palm or the parent's palm next to the child, and you might notice that this child looks pale. Now, pallor is a hard sign to notice. Not only can it be hard to interpret in children with different skin tones, but it is also very subjective, and it's also something that is about spotting something that is missing. In a previous talk, I mentioned that the absence of a physical sign, whether it's a child who's not interacting or moving normally, or a child who's got something missing from the way they're interacting with you, or in this case, the absence of pink, the absence physical signs are always harder and always take a little bit more time to think about. And a particular pediatric skill is to walk into the room and ask yourself the specific question, what is wrong with this picture? And this talk is really about if the answer is, I think this child might be pale. I think about pallor in two broad camps, in two ways of thinking about this. And before I talk about them, I'd like to introduce you to an idea of how we think about a differential diagnosis. Our job is to try and work out what's going on with a patient. And we do this through the history, the examination, and focus specific tests. I'd like to think about it as a bit like going to a night cricket game where none of the floodlights are turned on. You wouldn't be able to watch the game. The idea is to start turning on as many floodlights as you need, focused on the center of the pitch to allow you to watch the game and for the players to play. And our job is to turn the appropriate lights on to the appropriate intensity by asking the right questions and doing the right examination. Once we've turned those floodlights on, once we've done that focus history and that focus examination, the focus test, we're really then trying to think about a differential diagnosis. And there are many ways we might approach this. Unfortunately, the way that I think a lot of students are taught is to have a list. And you might have a list of causes of anemia, and you might have a list of causes of shock, and you might want to just work your way through those lists. Now, the problem with lists is that they're great if they're complete. However, if I go shopping with a shopping list and I've left something off the list, I'm not going to think of it. The other problem is that if I go to the supermarket with a shopping list, that shopping list is in a very random order. I'm not thinking about the most important things first and making sure that I don't forget those important things. The list is also not presented in the same order as the things in the shopping aisles, and therefore there's a mismatch between my list and how things are presenting to me. And therefore, I think lists are quite a dangerous way of doing medicine, and one that I would dissuade you from unless you really have to. Ultimately, it always comes down to a list, but the shorter and more precise the list, the better. And therefore, I would suggest to you that if we can get down to the point of thinking, right now, I need to have a list for causes of aplastic anemia. Well, that's not a list I carry around in my head. That's what I've got the internet and books for. But I have a way of getting down to this because I have a more structured approach to my differential diagnosis. There's a different way of doing a differential diagnosis, which I would call the common garden birds approach. In other words, what are the most common birds that I might see in my garden, or what are the most common causes of pallor in a child? And I just learn about the common causes. The problem with that is I might miss the serious and important if it's uncommon. And so this is quite a risky strategy as well. And so I might adopt what I would call the wild mushrooms approach. I'm only going to learn about the mushrooms that are going to kill me if I eat them, and then I can eat any mushroom. Well, that's okay, except for the fact that most children I see do not have a serious life-threatening illness. And if I'm constantly excluding brain tumors and meningitis in every child I see with headache, I'm going to do an awful lot of awful lot of unnecessarily normal tests on all the children I see with headache for other causes. And so the wild mushroom approach is quite a nice one in as much as you're thinking, well, at least I'm safe, but it might leave you not ready to manage and think about the more common, more mundane presentations we see in childhood. A different way might be to say, okay, well, I'm not going to have a differential diagnosis. That's what my seniors are there for. I'm going to have a really good way of asking questions. I'm just going to learn some really good questions. I'm going to ask a good first order question, and then I'm going to ask some questions that follow up. And I'm not going to have a differential. I'm just going to have a really good way of asking questions, like Socrates for pain. Brilliant. Except for you can ask all your Socrates questions, but it doesn't allow you to make your patient's life any better. And our job is to try and make people's lives better. So I'm not sure that that's a good approach. The approach I would always like to adopt, and this is what we're going to focus on in this talk, is to have an approach to a differential diagnosis, almost a bit like the game Guess Who, where we might ask a question and guess who, like, is the person male or female? Because that allows us to instantly split the field. And then we might ask, okay, so it's a man, do they have glasses or not? And then we can work our way down that in the game Guess Who, that's what we do. And I'm going to suggest that this is quite a useful way of thinking about the pale child. Because if a child is pale because they are poorly perfused, in other words, they're not perfusing the capillaries properly, then that child will have the signs and symptoms associated with shock, and you need to be familiar with those. You need to know what a normal heart rate is, or how to find out a normal heart rate for a 3-year-old child. So if the child's very tachycardic and you've noticed that they're tachycardia with a low volume pulse and a prolonged refill time, you can then be thinking, well, okay, they don't seem to be perfusing their skin terribly well. I wonder how they're perfusing their myocardium and do their blood pressure. I wonder how they're perfusing their brain and look at their mental state. I wonder how they're perfusing their kidneys and ask about urine output. So you're going to start thinking about the pale child in terms of the signs and symptoms and manifestations of shock. And that's a really quick way of getting in there very quickly in the shocked child. Because then you can start thinking, okay, well, what's my differential diagnosis of shock? Well, it might be cardiogenic shock. It might be neurogenic shock, or it might be a problem with volume. And that volume might have been moved around the body, what we call distributive shock, like we see in anaphylaxis or sepsis or hyperalbuminemia. Or it might be that there's just not enough fluid in the circulation, either because the child's very dehydrated or has bled or has vomited lots or had lots of diarrhea or lots of loss through the skin or through the kidneys in something like diabetic ketoacidosis. So when we think about a pale child, what I'd like you to do is to take a more of a guess who approach and go, okay, well, what are the signs and symptoms I would expect to see in a shocked child? What's this child's perfusion? What's their pulse rate? What's their pulse volume? And how am I now going to think about the signs, symptoms, and causes of shock? Whereas if the child is anemic, I might think, well, what are the signs and symptoms of anemia? Well, the child might be tachycardic, but they probably are well perfused, but they will have pale conjunctiva and pale palms. They might look anemic even though they're well perfused. And then we're going to start thinking about causes of anemia. Well, anemia we could think of as a bank balance. Is there not enough going in, or is there too much going out? If it's going out, is it being bled? In other words, has the child had an injury or bled internally? Or are those red cells being hemolyzed, chopped up by a process such as hereditary spherocytosis? So is there too much loss, either bleeding or hemolysis? Or is there not enough going in because there's a bone marrow problem? And what sort of bone marrow problems might we think about? Well, we might think about bone marrow problems where the bone marrow is not working, what we call aplastic anemia. Or we might think about bone marrow problems where the bone marrow is normal, but can't work normally because it's been invaded by cancer, such as in leukemia. And so what I would really like you to do is think in this session and go away, and when you're thinking about assessing children, think about how you're going to assess Pallor, how you're going to think about shock, causes of shock and manifestations of shock in children, and how you're going to think about anemia, causes of anemia and manifestations of anemia in children. But then as a more broad thing, I want you to think a little bit about how you're going to structure your questions around a focus, history, and examination for a focus structured approach. Are you going to think about it in terms of garden birds and common things occur commonly? Are you going to think about it in terms of wild mushrooms and always diagnose the important and treatable? Or you're going to just learn a list of really good questions? Or are you going to take a more nuanced approach, which tries to split the field up into causes? And how might those different causes, how might cardiogenic shock present differently from distributive shock, present differently from blood loss, for instance? And this is going to allow you to start thinking like clinicians think when they go and see a pale child.